Welcome back. What's the new part? Appendicular skeleton. We got quite a bit to go through. So if you're getting tired of watching these videos, take a break. You got all week. Alright, that being said, appendicular skeleton is quite a lot. Needless to say, axial skeleton was a lot. Appendicular skeleton is also a lot to take in and learn. Just remember that this is an introductory class, okay? So this is just an introduction to anatomy and physiology. And we spent a lot of time on bony landmarks and especially muscles. We're going to spend a lot of time on the muscles. Why? Because the majority of you all are majors in the exercise science program are going to go on to be ATs, PAs, PTs, OTs, RTs, all the acronyms that you can think of that are associated with healthcare providers. Okay? We like to spend a lot of time on the aspects of the appendicular skeleton that are going to be needed in the next few weeks. For instance, when we talk about the shoulder girdle here, or the pectoral girdle, and the same thing. We're going to talk about all the bony landmarks that are associated with muscle insertion. Okay? The majority of the bony landmarks we are going to discuss in the appendicular skeleton have something to do with muscle insertion. And why is this so important? Well, number one, when you guys get to your muscles lab, which is very soon, you're going to have to know the origin, the insertion, the action, so what the muscles or what the bone is doing and what the muscle's causing the bone to do. And you're going to have to know that in detail, okay? So when we teach you this week about the glenoid tubercle, or the supraglenoid tubercle, is the insertion of the, or is on the glenoid fossa, you're going to need to know in a few weeks that the superior glenoid tubercle, or the supraglenoid tubercle, is the insertion point, or the origin, really, of the long head of the biceps. Okay? So that's just an example of what you're going to need to know. So it's better to just start now and get through it now and start learning it now, so that way, when we get to the muscle section and you hear that word or you hear greater tubercle, it's not foreign to you, okay? You remember it and you understand it. All right? Okay. That little intro took way too long. Let's go ahead and get moving. And what I'm going to do is I think I'm going to bounce back and forth between showing you a model. For instance, the scapula. We're going to start with upper body. So I'm going to bounce back and forth between showing you this here and talking about the landmarks on here, and then having your PowerPoint pulled up. So we're going to be going back and forth because that PowerPoint is really good. So you have some good resources. Number one, the appendicular skeleton PowerPoint that's uploaded on Canvas is really good. It has a lot of landmarks that have to be filled in. So you could just download that and then type them in and use that as your practice resource, okay? So let's just go ahead and get started, all right? So we're going to start here at the scapula, okay? But really what I want to do first is talk about the pectoral girdle itself, and then the joints that are made up from the pectoral girdle. And I'm going to kind of write them on the board, okay? And I'm going to run through that real fast like I usually do. And then I'm going to talk about the different articulations or joints that are made with each. Because as you move forward and when you become a healthcare provider, you're going to be dealing with joints. You're going to be dealing with rehabilitation of our articulations and joints. You're not going to be dealing with, or you will, potential fractures of humeral shafts and femur shafts and stuff like that. But that's so easy to take care of. The more difficult stuff to take care of is in the joint itself, whether you're dealing with ligamentous damage, capsular damage, or potential muscle tears, okay, that are affect the joint. All right. So real quick, let me write up the shoulder girdle or pectoral. I call it the shoulder girdle, but it's also called the pectoral girdle. And I'm going to write up the joints for all of those, okay? All right, so there we have it, okay? So let's start off at the top here with the shoulder girdle or the pectoral girdle. And let's go over the joints of the shoulder girdle, okay? And I'll kind of hold this up too because this is our shoulder girdle. The only thing that's missing off of this is really how it sits along our rib cage. And this really kind of just sits on the back, okay? So starting with number one. I started with this because this is considered the true joint. So in any joint complex, the shoulder girdle or the pelvic girdle in your hip or the knee joint, the elbow joint, okay? There's several joints actually that are there, but there's always a true joint. And what I mean by true joint is I mean that this is the actual joint that is the main mover of that whole complex. So in the shoulder, the glenohumeral joint, which is the true ball and socket joint, that's right here, glenohumeral joint, okay? That's the true ball and socket joint of the shoulder, all right? And that's really your humerus and the scapula where they meet together. Your scapula is your shoulder blade, okay? So if I lift up the scapula here, this right here, the ball and socket, the socket is right there, okay? And so the socket is called the glenoid fossa or the glenoid cavity, okay? You can call it either one, glenoid fossa or glenoid cavity, all right? Now, this right here is the socket for the ball and socket joint. This makes up the true joint. You'll notice that joints, okay, or articulations really are just named for the two bones that meet. Either the two bones that meet or the aspects of the two bones that meet. So in this case, the glenohumeral joint, okay, is the humerus, all right, basically this guy, okay, the humerus and the glenoid cavity meet, all right? So we have the glenal, which is the glenoid cavity of the scapula, and the humerus, and they meet. So we have the glenohumeral joint. That's how joints are named, okay? So this is basically the start of our shoulder joint. This is what is the prime shoulder joint movement, okay? Now there's other joints in the shoulder complex or shoulder girdle, all right? And like this one right here, the acromioclavicular joint. The acromioclavicular joint is made up of the acromion process of the scapula, which you can see it on that model. It's right there, top-down view. It's also right here, okay? So on the superior aspect of the scapula, you can see the acromion, all right? The acromion is actually a portion of this posterior aspect of the scapula, okay? When we pull up the PowerPoint, I'll go over that in detail. And we'll probably do that after I get done with this informative section here about the actual shoulder girdle itself, okay? So the acromioclavicular joint is our second joint that we talk about. And that's basically our acromion meets with our clavicle. Our clavicle, okay, this is our clavicle. Our clavicle is our collarbone, all right? So where the acromion and the clavicle join together, as you can see right there, that's the acromioclavicular joint. This is real common if you've ever watched football and you hear someone say, oh, he's out for 2 to 3 weeks with a separated shoulder. That's what separates, the AC joint. We rarely say that they have a separated shoulder for just a dislocation of the glenohumeral joint, okay, or a subluxation of the glenohumeral joint. This is a dislocation or a subluxation when this pops out. If you hear, oh, I have an AC joint sprain or an AC joint separation or a separated shoulder. Usually we're talking about this right here. And it's when these ligaments, there's one on top, the acromioclavicular ligament, and then these ligaments through here, it's when those ligaments tear or become sprained, sprain is a tear, and when the clavicle juts up into the air or shoots up into the air. Okay, so that's the acromioclavicular joint, and that's what we're talking about when we're talking about AC joint separation or AC joint sprain. Okay, the next joint, which is associated with an AC joint separation, it's actually number 4 on my list right here. It's the Coracoacromial joint. Okay, the Coracoacromial joint, and that's right here. Okay, this is the coracoid process. If we look at our scapula without all this musculature, you'll notice a lot of these landmarks that we're talking about with all these joints and how they connect is with the scapula. Okay, and we'll talk about why here in a minute. All right, but I'm going to hold this up. So right here, this is the coracoid process. This is how you know you're looking at the front or the anterior aspect of the scapula. Okay, if you have the coracoid process poking outwards, kind of pokes out a little laterally, but if you have the coracoid process poking outwards or forward, this is the anterior aspect of the scapula. You know you're looking at the posterior aspect of the scapula because you have the spine of the scapula. Okay, this juts outward and it's quite large, all right, and it creates 2 fossas above and underneath. We'll go over those in a minute. Let's go back to the coracoacromial ligament, or coracoacromial joint. There is a ligament there too that holds the 2 joints together. So right here is our coracoid process. We see our acromion up top. So this actually extends ligaments up. Okay. Remember, ligaments hold bones together. Ligaments are what one of the main stabilizing forces of joints. Okay, joints have 3 stabilizing forces. One is ligaments. We call that static stability. Okay, so there's our ligaments of our coracoacromial joints. All right, so we have right here our coracoacromial ligament, and then the conoid and the trapezoid. You don't need to know the ligaments. Okay, but these are the ligaments here. All right, and they attach the coracoid to the acromion, the coracoacromial ligament here, and then these 2 attach the coracoid to the clavicle actually, and they help support the AC joint. Okay, so the 3 types of stability ligaments are: 1, that's static stability. Muscles also provide stability for joints. That's called dynamic stability. And then there's a vacuum. So all joints movable joints are surrounded by capsules that create a vacuum, and that helps improve stability. So the coracoacromial joint is another joint that we talk about in the pelvic girdle, or excuse me, not the pelvic girdle, the pectoral girdle or the shoulder girdle. Okay, let's go back up here. The sternoclavicular joint. That's a joint. If I put this like it's an anatomical position here, my clavicle, my collarbone comes up here to my sternum. Remember, we learned about the sternum in the axial skeleton. Okay, this meets up with the sternum right here, and then that's part of your shoulder complex as well. Lastly, I have this guy starred. Okay, technically, joints, articulations are where 2 bones meet. Okay, like this. 2 bones meet here. 2 bones meet here. Okay. However, there is what we call a false joint of the pectoral girdle or the shoulder girdle, and it's important because it has to do with glenohumeral and scapulothoracic rhythm. Okay, so how the shoulder moves up and then the scapula moves along the thoracic cage, and that's the scapulothoracic joint. The scapulothoracic joint is what we call a false joint. Why? Because it's not bone to bone. It's not the scapula to the rib cage. It's the scapula to muscle, like the subscapularis or the serratus anterior, and then it presses up against the rib cage. Okay, but it's not a true joint because it's not bone to bone. However, it is still an important joint or articulation, even though there's muscle in between, so it's a false joint. but it's still very important because maintaining the congruency of the scapulothoracic joint, the shoulder blade pressed up against the rib cage, is really important for shoulder health. Okay, and we'll talk about that more when we get into muscles. I like to make a lot of connections with pathologies and things that you're going to hear in healthcare because hopefully you'll remember it more. And if you're really interested in this stuff, then watch the video multiple times and try and grasp some of the stuff that I'm talking about here because it's very, very important if you're planning on going to PT school or AT school or OT school. Okay? All right, so with that being said, those are the joints. Now let's talk about the aspects, the bony aspects of each. And I'll kind of touch on, when we get to some of the bony aspects, I'll kind of touch on, okay, what ligaments actually insert there, and then what muscles insert there. And then that way you have a brief understanding of it. I would highly recommend you take notes. This quiz is no joke. This is very hard to just memorize. So please, please, please do your due diligence and make the connections. Take notes on what I'm saying, and then study, study, study. Okay? All right, so let's move on now to the actual bony aspects of everything, and then I'll go through it on your PowerPoint sheet as well, okay? Okay, guys, we're going to go ahead and just run through this relatively fast. Let's start off first with discussing the clavicle and then the scapula. So we kind of just went over the shoulder complex itself and the joints that make up the shoulder complex. I'll go over this on the model as we go through, and I'll kind of do that. We're going to hop back and forth between the PowerPoint slides and the model. You'll notice that these PowerPoint slides should match up relatively well with your identification sheet. So make sure you go in that PowerPoint that has everything ready for you to just list out and answer through, because all of these little arrows pointing to the aspects and the landmarks of the bone, you can go ahead and fill out. Really good practice for you guys, and a really good kind of assignment for you to do. Okay? All right, so pretty easy to see. We have the sternal end and the acromial end. Now, one of the important things about the acromial end, how you know you're looking at the acromial end, and it's hard to see on here, but the acromial end has a much flatter surface than the sternal end. The sternal end is much more cuboidal. So if you ever just happen to be holding a clavicle in your hand, the sternal end is going to be nice and flat. Or excuse me, the sternal end is going to be cuboidal in shape, and the acromial end is going to be nice and flat. Okay, so that's how you know you're looking at it. But that's what you need to know: sternal end and acromial end, because they both make up the two joints, the sternoclavicular joint and the acromioclavicular joint. Okay. All right. So here, the scapula. Here we can see. So this is actually a picture of a real bone, and you could I can tell it's a real bone just because of the integrity and the composition of it. It's not a fake plaster model. This is a real bone, and this kind of has everything that we need to look at and that we like to identify. So if we look at the anterior aspect first, and I know it's the anterior aspect not just because it's labeled, but because of the coracoid process. That's what I look for. So if the coracoid process is showing, then that is the anterior view. So we have the subscapularis fossa. That's where our subscapularis muscle sits or originates. We have the superior border, the superior angle. Now, here's something that I want you guys to understand. If we ever have a superior of something, most likely, in fact, around 99.9% of the time, we're going to have an inferior something. So if you ever see a directional term in front of a landmark word like border or angle, 9 times out of 10, there is going to be the opposite of that directional term. And what do I mean by that? So superior angle right there at the top, as you can see. And then if you go down, you see inferior angle. So whenever we're doing anatomy vocab stuff, know that if we see superior angle, there's going to be inferior angle. If you see lateral border, which is the side where the glenoid cavity is, that's the shoulder joint socket, okay? That's the lateral border along there. And then we have, if there's a lateral border, there's going to be a medial border. Now, it just so happens that the medial border is also called vertebral border. So you can use those interchangeably. You can call it vertebral border or medial border. Why? Because the medial border is along the side where we have our vertebrae or our vertebral column, okay? A lot of muscles originate along the medial border and lateral border, okay? All right. We see the glenoid cavity. It's not necessarily listed as the glenoid cavity, but that's the socket of the shoulder joint, okay? Our coracoid process and our acromion from our anterior view. If we look at the posterior view, how we know we're looking at the posterior view is right in the center that is more on the superior aspect of the posterior scapula, and that is the spine of the scapula, okay? The spine of the scapula. Really important landmark. The spine of the scapula or the spinous process of the scapula. The spine of the scapula goes up and forms into the acromion. Okay, that's on the top part of our shoulder. So if you take your hand and put it right on the top part of your shoulder, you feel that real bony aspect. That is the acromion, and then the clavicle comes up to meet that. Okay. So we have the spine of the scapula. The spine splits the posterior aspect of the scapula into two sections. Okay. We have the supraspinosus fossa. Supra meaning superior. Spinosus meaning spine of the scapula. Supraspinosus, fossa meaning cave. So that's the little cave above the spine of the scapula. The infraspinosus fossa, just like is the supraspinosus fossa. Infra meaning inferior. Spinous meaning spine of the scapula, so inferior to the spine of the scapula. Fossa meaning cave. Okay, so that's that cave or little cavity on that underside. Really important landmarks. Star those. You need to know those. Those are going to be the origins of the rotator cuff musculature. Okay. All right, so this is straight from your PowerPoint. I went ahead and half listed the stuff, so you can see as it says in there. Fill in the rest. Study up. Okay. So I want you to go through and I want you to fill out all these landmarks on here. But this is a lateral view of the scapula, and you can see the glenoid cavity there very well. The coracoid process, supraglenoid tubercle, lateral border of the scapula, and then the inferior angle. Okay. You go ahead and fill out those other markers. Those are pretty important. I want you to fill those out. Study up, go on through and fill those out. Okay. All right, let's go back to the video. Then we're going to jump back to this PowerPoint slide. Okay, so as you saw on the PowerPoint, we went over the landmarks in the clavicle and the scapula. So hopefully you were able to actually write that in and follow along there. On that PowerPoint, and then fill in the blanks there on some of that. Okay, so to recap on the model, here we have our clavicle. Okay, right here on the clavicle, the most important things that you need to know about the clavicle is how the clavicle turns and it bends. Okay, and it's done so like this to help provide support and stability. Okay. By the way, when the clavicle fractures, it actually does a really good job of healing. Every once in a while, you can have what's called a non-union fracture, where there's necrotic tissue in the bone. Necrotic means dead cells, and it doesn't heal quite as well. But it actually is pretty amazing at how well this bone heals, because it really does a good job of just finding its way and healing. It can be displaced, and it can still heal. Okay. But this end of the clavicle, like I went over earlier, is in the PowerPoint, is the sternal end, and then this end right here is the acromial end. Okay, so we have the sternal end and the acromial end here. Okay, here you can see all those important landmarks that we were talking about on the scapula. All right, and why they're important? Well, because this is all musculature. This is actually the rotator cuff muscles, and you're going to have to know these and know the origin, insertion, and action of all of these. Okay, there's 4 rotator cuff muscles, and this is all 4 on here. And you can see all those landmarks that we were talking about are because of not all of them, but almost all of them are because of attachment points, either origins or insertions of muscles. Okay, so there's a reason why we go through all of them. Okay, if we take it away, you can see here. So what did we go over on that PowerPoint? Well, we went over here. This is the anterior aspect. We have the subscapular fossa. Let's knock out all the fossas real quick, okay? Here we have the spine of the scapula. Okay, remember, the spine of the scapula splits these two fossas. Really easy named the supraspinosus fossa, right? Supra meaning above, superior. Spinosus meaning spine. So supraspinosus fossa. And then here, the fossa underneath is infraspinosus fossa. Inferior meaning below. Spinosus meaning spine. So infraspinosus fossa. Okay? So subscapularis fossa, supraspinosus fossa, infraspinosus fossa. Interestingly enough, when we get to the rotator cuff musculature, it's going to be pretty easy to remember these. Why? Because this is the subscapularis muscle, the infraspinatus muscle, and the supraspinatus muscle. Okay? So pretty easy, all right, when we get there, as long as you remember the fossas, all right? And you will. Everyone does. You know, right now it seems a little daunting, but you'll get this. All right, so we've already gone over the coracoid process. There it is. The glenoid cavity, or the glenoid fossa. The acromion process is a part of, or comes out of, the spinous process. Okay? And then we have the vertebral border. Okay? The lateral border. The inferior angle. Okay? Superior angle. Okay, those are the kind of the important aspects of it. Because when we get into the muscles, you're going to have to know that the teres major originates on the distal 1/3 aspect of the medial lateral border of the scapula. You know, something like that. Okay, but for the here and now, just know lateral border, vertebral border, inferior angle, superior angle. Okay, coracoid process. All that stuff. All right? So that's the scapula. Okay? And that's the clavicle. All right? So now let's just keep steamrolling on and let's go to the humerus. And let's pull up your PowerPoint first and let's talk about that and go over the humerus. And then what I'd like to do is we'll actually show you the actual bone itself. If we're in lab, you would be grabbing this and kind of, you know, okay, what is what? And let me hold it and let me do stuff with it, okay? But what I'd like to do is kind of teach you how you know which way is what on this bone. But first, let's look at that PowerPoint and go over the humerus, okay? Okay, the humerus, all right? The humerus has several landmarks, and these are kind of the main ones. And you can go through, use this as a reference, this video as a reference to go ahead and fill out that PowerPoint slide with all of the landmarks that are not labeled that you have, so that that'll be just a good practice assignment for you. But let's go ahead and start at the top of the humerus. Now, when I hop back over to the model, I'm going to show you how you differentiate between a right and left humerus, okay? Humerus is your upper arm bone, okay? But I'm going to show you the model, and I'm going to show you how you figure out what type of humerus you are holding in your hand, whether it's a left or a right, okay? But let's start at the top. So the portion of the humerus that articulates with the glenoid cavity is called the head of the humerus. This is going to have Highland cartilage or articular cartilage on it. That's that pearly white substance. If you ever eaten a chicken wing, okay, good old chicken wing, you will notice that on the chicken wing, the pearly white substance on the, let's say, the chicken bone, that is Highland cartilage or articular cartilage. Strongest compressatory force cartilage in the human body. Really good stuff. When that degrades away, not good because it doesn't really grow back well on its own, and that'll lead to arthritis. Okay, so whenever we have a degrading away of that white pearly substance, we call that arthritis. Okay, so the head of the humerus is covered with that cartilage. And that's what articulates with the glenoid cavity to make the glenohumeral joint, as we went over earlier. Okay. Almost all ball and socket joints has a anatomical head, has a head, then has an anatomical neck, and then has a surgical neck. Okay, the reason why we differentiate between an anatomical neck and the surgical neck is that so we can identify the portion of the humerus or the femur when we get to the femur that we use to do joint replacements. So the surgical neck, as you can see there, that's listed surgical neck. That's the area where we cut, or not we, but orthopedics will cut to then insert the joint replacement's new head of the humerus. Okay. But up on top there, that's the anatomical neck, just distal. So here's when distal and proximal get used interchangeably, or get used a lot, rather than superior and inferior. When we're dealing with the appendages, it's always easier to talk about distal and proximal versus superior and inferior. Okay, so just distal to the humeral head, we have the anatomical neck. Then on the anterior aspect, okay, the anterior aspect of the humerus, which is the right-hand side, that's B. B is the anterior aspect here. So on the anterior aspect, you really get a good view of the lesser tubercle, the intertubercular groove, which is also known as the bicipital groove, and then the greater tubercle. Okay, these are very, very important landmarks. All right, the greater tubercle, the lesser tubercle, and the intertubercular groove, or the bicipital groove. Star those, write those down, take notes on those. Those are very, very important. I can almost guarantee you that one of those is going to be on your quiz, and also you're going to need to know those because when we get to muscle anatomy, you're going to have to know that those are the insertion points for the rotator cuff and several other muscles as well. Okay, so the greater tubercle, lesser tubercle. The lesser tubercle, if we're holding our humerus, the lesser tubercle is on the medial aspect of the humerus. The greater tubercle is on the lateral aspect of the humerus. That's how we know which side is medial and lateral. And the lesser tubercle, when you're looking at the humerus anteriorly, the lesser tubercle is in view. If you're looking at the humerus posteriorly, which is A on this slide, you cannot see the lesser tubercle. Okay, but you can see the posterior aspect of the greater tubercle because the greater tubercle kind of wraps all the way around. All right, it goes from anterior all the way to posterior, and the greater tubercle is on the lateral aspect. Okay, the lateral aspect of the humerus. The head of the humerus always points medially, right? It has to because it goes into the socket, the glenoid cavity. So whichever way the humerus is pointing, that's what's going to help you determine which side of the humerus you have. Okay. So in the instance of the picture of the slide, all right, the type of humerus that we have here is a right humerus. So this slide is a right humerus, okay? And when we get to the model, I'll explain how you know how to do that, and that's pretty easy. But it has to do with the location of the head of the humerus and where the head of the humerus is pointing. All right. Okay. So moving on down the line, lesser tubercle, really important. A lot of muscles attached to it. Greater tubercle, really important. And then intertubercular groove. So you need to know those. As we go down, we have the shaft of the humerus. That's the main middle portion of the humerus. Not listed here. But the whole main middle portion of the humerus is the shaft. It's just the long bone portion of it. If we take our finger and we go on the greater tubercle up top and we slide down the shaft of the humerus, we get to a large nubby portion. This large nubby portion is called the deltoid tuberosity. This is where our deltoid muscle inserts. Okay, so this is why you need to know this landmark. So the deltoid tuberosity is on the lateral aspect of the humerus, and you basically slide your finger down from the greater tubercle. Okay, the distal portion of the humerus makes up the elbow complex. Okay, and I say elbow complex because there's multiple joints down here. All right, really, technically, there's 3 joints down here. Okay, we have the ulnar, they're the humeral ulnar joints, or the ulnar humeral joint. We have the radial ulnar joint, and then we have the radial humeral joint, okay, or the humeral radial joint. All right. It depends on what text you look at, the way they verse it. Okay, but the true elbow joint is the ulnar humeral joint. Okay, because the ulna fits into what's called the Olecranon Fossa there. All right. So if we look at the distal aspects, let's look at B first. That's anterior. We have the capitulum, okay, and the trochlear. All right, those are 2 articular surfaces, okay, really important surfaces there. The capitulum is the aspect of the elbow that basically the radius rotates around. Okay, so the radius is responsible for supination and pronation, and the radius rotates around, or kind of rotates among the capitulum. Okay, there's a thick piece of cartilage there, and almost like this fibrocartilage substance kind of around the radius at that point, the radial head. And when we get to the radial head, you'll see what I'm talking about. Kind of hard to visualize this, but when we get to the model, it'll be a little bit easier. But I just want to introduce you to some of these terms here and go over this slide. But when we go over the model, I'll kind of show you how it works. It's too bad you can't hold on to the models and do it yourself. But all right, the trochlear is where the ulna kind of rides up and down or across. That it allows the elbow joint, the true elbow joint, the ulnar humeral joint, to perform flexion and extension. Okay, so when our brachialis muscle flexes our ulna up, our ulna rides along the trochlear and goes up, and then when our elbow gets extended because our triceps are activated, our ulna shifts into extension and moves along the trochlear posteriorly. And then the back part of the posterior aspect of the ulna actually fits into that, on the diagram A, the Olecranon Fossa. Okay, that's the back part of our elbow joint. All right. So, you know, I'll let you guys kind of look at this and study it up. Know these landmarks: medial epicondyle, lateral epicondyle. You can see that on both sides. But that's kind of the important stuff of the humerus. Now, what I want to do is go over that with you in detail with the radius in the ulna and go through that. So let me hop back over to the model and show you what that looks like on the model and how the ulna and the radius rides along there. And then we'll come back to the PowerPoint to talk about radius and ulna. Okay, so we just got done with the PowerPoint there. Let's go back to this model. Okay, so how do I know if this is a left or right humerus? What do I do, right? And this is actually a real bone. This was once on someone. This isn't composite. I can just tell just because it has real bony tissue on it and the way that it feels and the composition of it. Okay. So what I want to do, and this is going to be a little bit difficult to do on video, but what I want to do is just kind of show you some of the distal aspects first. This is what I do first. Is I hold this up, and I'm just going to show you both sides. Okay, you see how there's those divots in there? So this divot right here is quite large as compared to this size. Okay, these divots are fossas, right? And we've already gone over this in the PowerPoint. But right here, this is the posterior aspect. This is how I know I'm looking at the posterior aspect, because there's one large fossa, and this is the Olecranon Fossa. So what I do is I take this and I put my thumb in it, okay? And then I hold it like so. Now, when I put my thumb in that, my thumb fits nicely into the Olecranon Fossa. That's how I know I am holding the bone up so the anterior view is showing. So I'm holding this bone so the anterior view is showing. So if I'm holding this and the anterior view is showing, my thumb is in the Olecranon Fossa. I always know, this is always true, that the head of the humerus points medially. It has to, because it goes into the socket, right? It goes into the glenoid cavity. So it always must point medially. If this always points medially, and this is anterior, then you know, if you have those two pieces of information, which side is anterior and which side is medial, you can determine what side this bone is. So, which side is this on? My left or right side? No one is answering because I'm talking to myself here. All right, so this is the left side, okay? Because this is anterior, and I'm facing you anteriorly, right? And this is the medial side. So this is my left humerus, okay? Not mine specifically, obviously, but this is a left humerus, okay? So this is the medial border, and this is the lateral border. So now that we know what direction this is, let's go over some of this stuff. So let me zoom way in here, okay? So here we have the head of the humerus, just along this border here. This is the anatomical neck, okay? So anatomical neck, all along the border of the head of the humerus. Remember, this is Highland Cartilage, all right? And we know we're looking at the anterior aspect because we see the lesser tubercle. The lesser tubercle is in view when you're looking anteriorly. Posteriorly, it is not, but we do see the posterior aspect of the greater tubercle, okay? So anterior, we have the lesser tubercle, the bicipital groove, also known as the intertubercular groove. It's called the bicipital groove because the long head of the biceps muscle goes through there, okay? So intertubercular groove, and then just the most lateral is the greater tubercle. So remember, I find my greater tubercle, really important landmarks for all of my muscles that attach onto it, okay? I find my greater tubercle, I know it's on the lateral side, and then now I'm going to take my finger and slide down. As soon as I feel a nubby portion, a rough nubby portion, that means muscles insert in there, that's the deltoid tuberosity. So once again, greater tubercle, slide my finger down, boom, right there I feel rough and nubby. That is the deltoid tubercle, or deltoid tuberosity, excuse me. Okay, then I can continue sliding, and I'm here on the lateral aspect. I'm going to put my thumb in that divot. That's how I know I have posterior facing me, anterior facing you. Here's the lateral epicondyle. Okay, and then here is my capitulum, my trochlear. Okay, medial epicondyle. All right, I flip it over to the back. I see my Olecranon Fossa. Okay, so that's the posterior aspect. All right, posterior aspect. All right, so that's basically the humerus. Okay. Okay. Let's take a break from there. Have a little break. We're going to go into the PowerPoint for the ulna and radius, and then we'll do the carpal bones as well. Okay, and then we'll be done. We'll be done, thankfully. Okay, with the radius and the ulna, as you saw in the model, I kind of showed you how they work with the elbow joint and kind of how they act on the humerus and act on the elbow joint itself, or really kind of perform their movements in the elbow joint, right? Supination, pronation, and then elbow flexion and extension. Okay. But here what I want you to do is utilize this to help you complete that PowerPoint sheet. All right, I'm going to just go through this really, really fast and really just kind of go over the key terms, and then I'm going to lift up the model again and once again show you on the model the key points that I want you to know. So first and foremost is the radius. Let's go over the radius. We have the radial head. Radial head is really important. It's circular in nature, and that is really what helps to ride around the capitulum and over the ulna to perform supination and pronation, kind of like how I showed you earlier. Okay. Just distal to the radial head is the radial tuberosity. This is an important landmark because this is where your biceps brachii inserts. Okay, the biceps brachii is what helps to perform supination of the forearm. So it really doesn't perform elbow flexion. Another muscle does that, and we'll go into detail on that when we go over muscles. Okay. I'm not going to go through all these landmarks. You can see it and you can label it yourself. So like radial notch, you can see the radial notch. You can label that yourself. I'm just going to do the important stuff. So the trochlear notch is really important. That's the aspect of the ulna that sits into the trochlear of the humerus and rides along the trochlear of the humerus. Okay. If we look at the posterior aspect of the ulna, we see the Olecranon process that fits in to the Olecranon fossa on the humerus. Okay. So really important, the back of the elbow joint, the true elbow joint on the ulna, that's the Olecranon process. Okay. On the distal aspect, what's important for you to know? The styloid process of the ulna. So, and I'll show you this when we go over the model, but if you pronate your hand, you can see the styloid process very well. It kind of pokes up. And then we have the just proximal to the styloid process of the ulna is the ulnar head, okay, or the head of the ulna. All right. Okay, so you can kind of see there and then list the rest of the stuff. Let's go over the hand real quick, and then I'll hop back over to the model and we'll go over radius, ulna, and then the carpal bones of the hand. All right, with the carpal bones of the hand, absolutely take some notes and then use the PowerPoint to fill out the blank portion of this, because there is no good way to learn this. There is a little acronym you can use to try and memorize this. But there's no real easy way to memorize this. So go through, or at least I didn't think so when I was a student. So go through, just learn them from proximal row and then distal row. Proximal row is the row that's closest to the radius in the ulna. Okay, if we start thumb side, it starts with the scaphoid. So if we're going, from lateral to medial, if we look at our body in anatomical position, lateral is thumb side, and then we go to medial, so we're fully supinated in anatomical position. So from lateral to medial, our pinky's on the medial side in anatomical position. Okay. So we start with the scaphoid. Okay. It goes scaphoid, lunate, triquetrum. Okay. The triquetrum is attached to the pisiform. All right. And then our pisiform kind of comes off of it. If we're holding our hand in a supinated format, you can press your thumb just along your wrist joint and you can feel your pisiform very well. Our scaphoid is in an area, if we hold up our hand, and I'll show you this when we do the model, I'll demonstrate it in front of you to show you, but if we hold up our hand, thumb side pointed towards our face, we have a little area of our wrist that we call the anatomical snuffbox, and that's where our scaphoid is at, and I'll show you that when we go over the model. But so it's our scaphoid, lunate, triquetrum, and pisiform. If we go to the distal row, starting at the thumb side and going across, we have our trapezium, trapezoid, capitate, and hamates. Hamate is really important because if we hold our hand supinated, so like we're holding a bowl of soup, our palm is up in the air, there is a portion, and I'll show you this on the model, of the hamate that has a little hook. And we call that the hook of the hamate, and that's on the pinky side. Now, here's where we get to the easy stuff. When we're talking about metacarpals and phalanges, it's really just numbers 1 through 5. That's what's nice. So metacarpal 1, 2, 3, 4, 5, that's all in the palm of our hand, or the dorsal aspect of our hand. That's our palm. We haven't gotten to our digits yet, so that's all connected tissue, okay? So our metacarpals are the connected tissue, or the palm of our hand. They make up the brunt or the large portion of our palm of our hand, okay? So metacarpal 1 is our thumb, metacarpal 5 is our pinky side, okay? Then when we get to our fingers, our digits, they're called digits or phalanges. Super easy, same thing, 1 through 5. Thumb is 1, 5 is pinky, okay? The thumb, we have a proximal phalange or digit, and we have a distal phalange or digit. When we get to our main fingers, not our thumbs, so 2 through 5, we have 3 bones, right? That helps us so we can make a good fist and curl our fingers all the way, all right? I'll show you that on the model as well. But we have proximal, middle, and distal, and they're named 1 through 5, okay? All right, so that is upper limb. That'll take it from there. So let's go to the model. We'll review radius, ulna, and the carpal bones, and then we'll be done with part 1 here. All right, back to the model. So we just went over the PowerPoint for the radius and the ulna. So I have a radius and an ulna here, and then I have a just a single radius with a hand connected to go over the carpal bones here. Okay, so once again, I'm just going to go through this briefly. A lot on you guys, a lot on you to go through your book, read this chapter. You know, I know we rarely ever open our textbooks, but man, your textbook is a really good resource. So use that as your resource. Use Google. Google some of this stuff. Google radius, okay? And then obviously this lecture that I'm giving you. Go through this whole thing multiple times, okay? All right. So radius and ulna. Okay, this is my ulna. You can see how it's a hinge joint. It hinges along my humerus, and I'll pull that humerus back out in just a second to show you that, but let me just show you. This is the proximal end. Remember, distal and proximal is better used for limbs. Proximal end of my ulna, right? This is anterior. This is posterior. Here's my distal end, anterior, posterior, and then here's my radius. Okay, this is my anterior aspect, and my radial head right there. Posterior aspect, anterior, posterior. Okay, so let's talk about the landmarks on it, and let's show you how it kind of works along with the humerus. Okay, so we take our ulna, and our ulna fits into our humerus there. Okay, let's go posterior. We see the Olecranon process of the ulna. That's that pointy part. That's the pointy part of your elbow, basically right here. Okay, so we have it fit in. So at full extension, that pointy part of the elbow fits into the Olecranon fossa. So the Olecranon process of the ulna fits into the Olecranon fossa of the humerus. As we go into flexion, okay, as we go into flexion, you can see how the ulna fits in and just fits real nicely into the humerus there. Okay, and it just rides along. That's the hinge joint there. That's the true elbow joint, the radial or the humeral ulnar joint or the ulnar humeral joint. Tomato, tomato, whatever you want to call it. Doesn't bother me. And that's the medial side. Okay, remember that the ulnar humeral joint is on the medial aspect. Okay, all right, so lateral aspect. How does the radius turn about? The capitulum. Okay, so there's our capitulum. And then we have our radius here. And our radius is just going to rotate, supinate and pronate, supinate and pronate. Okay, that's all it does. It just rotates around. There's an annulus, the ligament that rotates around here, and protects this joint. And this is actually spaced out a little bit from it. It's not all the way up on there. So this joint really doesn't touch like per se or some other joints do. It kind of is spaced out a little bit like that, and it rotates around like so. Okay, so that's the arthrokinematics of the elbow joint there. Not in real high detail, but in enough that you can, a nutshell, kind of understand it. All right. So let's start with the ulna. Remember, we have the Olecranon process, the pointy part of our elbow. Okay, we have the trochlear groove here. Okay, this is that goes along the trochlear of the humerus. The shaft of the humerus is here, and then you see the styloid process right there, or not humerus, excuse me, the shaft of the ulna. And then here you have the styloid process of the ulna right here, and then the head of the ulna. Okay, the head of the ulna is on the distal aspect of the ulna versus the head of the radius is at the proximal aspect. Okay, this is where supination and pronation occur. Okay, and remember the ulna is flexion and extension, flexion and extension. Okay, so remember here, supination, we're holding a bowl of soup. Okay, pronation, pouring out that bowl of soup. Really easy way to remember that. Okay, supination, pronation. That's the radius and the ulna doing work here. Okay, so the radius is rotating about the ulna. All right. Okay, that's pretty good. You guys can look at your resource sheet for the rest. I'm going to move on just for time's sake, so these videos aren't so long. And let's real quickly just go over carpal bones. Okay, so this is anterior or palmar aspect, posterior or dorsal aspect. Remember, we always talk about the frame of reference is anatomical position. That's when we're supinated. Okay, so if we take our hand, and I talked about this when we went over the PowerPoint slide. If we take our hand and we put our hand like so, you see those tendons right there, okay, right here. I take my thumb, I abduct my thumb, abduction, that's what that's called. So I'm bringing my thumb out, that's abduction. When I go into abduction with my thumb, I have these two tendons right here. Okay, I'm not going to go over what the tendons are, but you can see how it makes this marker here. This is called the anatomical snuffbox, okay? Way back in the day when we used to be cowboys and ride stuff and we had snuff. I don't know why my voice goes that direction, but they would take the snuff and they'd put it there and save it for later. Disgusting. I don't know if that's actually true, but that's what I've heard. That's how it was taught to me by my anatomy professor. But anyways, so that's the anatomical snuffbox. If I take my finger and jam my finger in the anatomical snuffbox, you are touching the scaphoid. Remember, the scaphoid is the first carpal bone that I want you to learn how we go from, in order, on the lateral aspect, thumb side is the lateral aspect, going from lateral to medial on the proximal row. Almost messed up there. Proximal row. So, it's scaphoid, okay? So we start with the scaphoid, all right? Then we go scaphoid, lunate. Interestingly enough, if I take my hand and I go down to here, my ring finger points to my lunate. So you have your scaphoid, oops, excuse me there. Scaphoid, ring finger should point to lunate. So our lunate, okay? And then our triquetrum, and then pisiform, okay? So remember those. Scaphoid, lunate, triquetrum, pisiform. Okay? These words kind of get a little weird and jumbled around at times. So make sure that you practice the spelling on these, because triquetrum is spelled very weird. All right, so we have scaphoid, lunate, triquetrum, pisiform. The pisiform is attached onto the triquetrum, okay? So we can see the pisiform there. If we go just distal, okay? So we're now on the medial side, and we're looking at the distal row, okay? We have the hamate, and the hamate has what's called a hook of the hamate, Okay, so this is where it's too bad you guys can't grab this bone and do some stuff with it, but this is the hook of the hamate right here. Okay, from our hamate, we go next to our hamate, and we have the capitate. The capitate is the largest of the carpal bones. And sorry, my fingers are in the way. All right, but the capitate is the largest of the carpal bones. Easy way to remember the capitate, it's the captain of the carpal bones. It's the largest of them. It's right in the center. Okay? So it's the captain of them all. It's the capitate. All right? Then next to that is the, as we go more lateral, is the trapezoid and then trapezium. Distal row. Trapezium. Trapezoid. Capitate. Hamate. Proximal row. Scaphoid. Lunate. Tricutrum. Pisiform. All right, so that's the carpal bones. I got no easy way to remember that. You could do it. You can look up that little acronym song. There's some sort of song for it. I don't know, and I'm not going to sing it. All right, easy stuff. Metacarpals, phalanges, right? Our metacarpals are the palm of our hand, the dorsal aspect of our hand. That makes up our metacarpals right there. And then here are our phalanges. Okay, our phalanges are made up of 3 bones. For these 4, right? Numbers 2 through 5. This is 2, this is 5. So from numbers 2 through 5, we have a proximal, middle, and distal. Okay, proximal, middle, and distal. That helps us so that we can curl our finger. All right, and then phalange number 1, we only have a proximal and distal. Okay, and then this is our metacarpals here. Metacarpal 1, metacarpal 5, phalange 1, phalange 5. Okay. All right, that is all that in a nutshell. Hopefully you got it. Study up. Don't just rely on this video. Use all the resources possible for you to learn. Stay frosty, folks. I'll see you next time when we do lower appendicular. That'll be part 2.